inside the colon or the rectum. Some of these polyps will become cancerous over time, and as the cancer grows, it can spread beyond the colon and to other organs. In 2017, there were 135,000 new cases of colorectal cancer diagnosed. Today, we have over 1 million colorectal cancer patient survivors. But despite this, colorectal cancer remains, typically in the top 3 of causes of death in our country. So what can we do? Obviously, early detection means everything. Mm-hmm. And there are things that we can do to obviate getting colon cancer. So who's at risk? First of all, there are risks that are out of control. First, age. Used to be 50, now it's 45. And the reason for that is that we have found that between 1994 and 2014, the incidence of rectal cancer has doubled. In fact, a recent analysis showed that adults born in and around 1990 have 2 times the risk of colorectal cancer, 4 times the risk of developing rectal cancer when they're compared to individuals born in 1950. Mm-hmm. Why is that? We don't know. Oh, okay. And so that highlights the importance of being involved in our care and doing everything that we can to identify these polyps or malignancies early.
Mm-hmm. So you said the age 45.
45 now.
That is the age at which we should start typically to get our
qualified
our screening
testing, yes.
Okay.
And that means not necessarily a colonoscopy, but colorectal cancer should be on our radar. We should be testing for blood in our stools, and any positive result would equate to an early colonoscopy.
And if someone has a history earlier than that, or
history of colorectal polyps, then that depends on what the type of polyp that you had. If you have inflammatory bowel disease or family history of colon cancer, then that will put you into a different higher risk category. Inherited syndromes, they are, although rare, we get about 4,000 cases a year, and they are horrific because they're not typically polyp related. Okay. Certain racial and ethnic backgrounds put you at higher risk. Type 2 diabetes. Those are things that largely we can't control without early identification. But there are things that we can control. Weight, for instance. Higher the weight, higher the BMI, the greater the risk of colon cancer. Lower activity levels, greater the risk. Diet is very important. Mm-hmm. Avoiding tobacco products, very important again. Heavy alcohol use, avoiding heavy alcohol use is important. And we can talk about that at length. We don't have that much time today, but I encourage patients to have these discussions with their primary caregivers. They're involved and they know what to do. As far as symptoms go, patients will often ask me, well, doc, what do I have to worry about? What are my symptoms? Mm-hmm. Well, understand, we do not want you to have symptoms. If you have symptoms, that means that you had a polyp, it has grown, and you are becoming symptomatic from what is most likely a colon cancer. Okay. We're trying to avoid that at all costs. But change in bowel habits, rectal bleeding, blood in the stool, crampy abdominal pain, weakness, fatigue, unintended weight loss, those are all things we'd like to...
Warning signs.
Yes.
They are the warning signs we look out for. So we have the screening, the colonoscopy. Obviously, that's what you're involved in frequently within your office.
Yes.
And you and I have talked in the past, and I have the personal experience, that there are new ways being developed all the time to do the colonoscopies and to treat colon cancer when it becomes evident.
Yes, exactly. Well, there are multiple tests that you can get prior to the colonoscopy. The most commonly used one is a digital exam. A single digital exam is not enough. Mm-hmm. It lulls you into a false sense of security. Up to 90% of colorectal cancers can be missed that way. And that's why fecal occult blood testing is very important, whether you have a Cologuard done, whether you have the immunochemical study done. They're all part of what we need to do for early detection. Cologuard, we're seeing more and more of. There is a false positive rate, which spans between 9 and 15%. With that, that means the Cologuard study is positive. We go in colonoscopically at that point. We find potentially nothing. Mm-hmm. If we find nothing, then what does that mean? We have a heightened sense of awareness. We put that patient in a different category, maybe a more urgent follow-up instead of 10 years, 2, 3, 5 years, depending on family history. Mm-hmm. There are other studies, but no one study is perfect. And I urge patients to involve their physicians mm-hmm. in their care, be involved in their own care, and focus on things that you can do. Diet. A Mediterranean diet is one that's sustainable.
The various methods by which we can make sure, or maybe mm-hmm. Improve our odds of not getting colon cancer are, there are so many of them, and I'm sure that there are all kinds of resources out there to tell us about them. But one of the things I wanted to focus upon with you today is when a colon cancer is detected is one thing, but the actual prevention through the removal of polyps is a real key, mm-hmm. especially to what you do.
It is.
Because those are precancerous. The polyps are precancerous, and
correct.
If you can get them at that stage,
yes.
then that absolutely prevents. That's the shield.
And we do that, and we do that commonly and regularly. Mm-hmm. And it is a shield. It's one of the only things that can be done once you have a polyp. Identifying the polyp and removing the polyp, colonoscopy is the single best study to have done.
Mm-hmm. So that journey is going to begin with our primary care physician.
Yes.
Who, should he or she be suspicious of something, is going to send them to your office.
My office, but there are other clinicians in the community, certainly mm-hmm. Dr. Gudetti, Dr. Amin, Dr. Barnacle.
Uh-huh.
Dr. Kramer
is new.
Brand new guy, great guy.
He's in the same office as you?
Yes, he is, right uh-huh. across the hall.
Okay.
And so there's no shortage of endoscopists in the community, and all of us are busy, and it's a vital role in the prevention of colon cancer in our community.
When you talk about colon cancer treatment at the Indiana Regional Medical mm-hmm. Center and the advances that have been made in the technology, you've been right there at the forefront of that too.
Yes, I've been very fortunate that way. I was, I came in '89 right out of training. I was classically trained. We were doing all procedures open, and then we shifted to laparoscopy. And then a few years ago, robotics came into play. And once you start doing robotics, the benefit to physicians, the benefit to patients is so great, mm-hmm. you just really never look back. And if a community or hospital or physician does not offer robotics for colorectal surgery, then you owe it to yourself to look further. We're very fortunate because we have 4 surgeons who do colorectal cancer surgery and non-cancer surgery robotically in our community.
You told me before an amazing statistic, and that is that the robotic surgery at IRMC, in terms of Pennsylvania, Ohio, West Virginia, mm-hmm. It is the most used?
Yes. So this is all data that's published with different organizations, and we at Indiana Hospital have the highest robotic utilization in a tri-state area.
It's amazing.
It is amazing. So much so, actually, that we are in the market for a second robot. Well, we have been able to recruit a bariatric surgeon who'll be here within a year. Mm-hmm. We have recruited a urologic robotic surgeon. He'll be here in June. And gynecology is really getting busier and busier robotically also. So it's a service to the community. And unless you, and even now I'm amazed by it. I did a 6-hour, probably the most complicated colon case I've ever done. I don't think I could I couldn't have done it laparoscopically, but I was able to do it robotically. I didn't have to open that patient. And amazingly, I did that surgery on a Tuesday. She was ready and willing and wanting to go home by Thursday morning.
Wow. Wow. The precision that because you did go through from open to laparoscopic to now robotic, the precision that you're able to achieve with the robotic surgery. And I think that's probably a misnomer, robotic, because you are still the surgeon in control of the instrument.
That's true. It is a misnomer. It's a $2.5 million tool. And without the surgeon, it just sits and collects dust.
Yeah. So you are sitting there at the device, and
Yes.
you are using it on the patient.
Yes, right next to the patient.
Yeah. And for you, did you think when you got here in 1989 that you were going to be, well, obviously you couldn't have thought that far ahead to say, this is what we're going to be using in 30 years.
The average person can't think of that. I mean, you just can't imagine what technology will bring. And it astounds me that it's even in the short span of 3 years, the technological breakthroughs that are occurring that we're able to offer patients. It's just, I'm astounded by it. I'm privileged and grateful to be a part of it.
We're talking about colorectal cancer awareness. We're going to be doing that all this month with Dr. Billon and with others. And for folks who want to begin that journey of ensuring against getting colorectal cancer as much as can be done, the primary care physician is the first place to go.
Typically, yes.
And based upon those recommendations, that's when they would see you or some of your fellow surgeons.
And please, I would urge patients to ask questions. Take control of their lives, and be partially responsible for their own care. And I think that's how we win this moving forward.
Absolutely. Dr. Billon, thanks so much for coming in to be with us.
Thank you. Thank you for the opportunity.
We appreciate it. It is the voice of Indiana County, WCCS AM 1160 and 101.1 FM. That's Dr. Andrew Billon with us here this morning. And we're just about up to the marker.